Okay, we're going to go ahead and get started. I'm going to introduce our grand round speaker, which most everybody here knows is Dr. Heidi Brown, who went to Brown for undergraduate. And then she went to Pitt and then finished up at UCSD with her fellowship. While she was there, she also obtained a master's in advanced studies in clinical research, which, as you saw when she asked all those questions today, so she is a guru in the research area. She just recently finished a capstone project here last month at UW on community and clinical outreach studies. In addition to her clinical work, she presents all around the world and has won all kinds of awards, Japan and Canada and all around. Just in the last 2 years, the International Continence Society, she got the meeting's best clinical abstract. At OGS meeting in 2016, the best evaluation and testing paper. And then she's got about 5 pages worth of single-spaced publications on here that I'm not going to go through. And funding, she is a K Scholar through the Department of Urology and has done all kinds of great work, and recently just received another grant from the Wisconsin Partnership on Health Outcomes on her community-based project. Dr. Brown is going to talk about tackling the taboo and updating the undercarriage. Where are we with pelvic floor disorders?
Okay, good morning, everyone. I'm going to try to speak more softly because I feel like this mic is really loud. I'm really excited to talk with you all this morning. There are props here for demonstration that are going to be passed around, so I think it'll be easier if you move down so that you're sitting closer. You're not obligated, but I won't be offended if you leave early, and if we're all close to each other, then it's easy to pass around the Eclipse vaginal bowel control insert, which I know everybody wants to get their hands on. All right. So, hi, good morning. I have some disclosures. I am going to talk to you this morning about pelvic floor disorders, which you know is my favorite thing to talk about. And my especially favorite thing to talk about is accidental bowel leakage. So I'm really going to spend most of the time this morning talking about that. But then I will also give a little bit of an update on where we are with disorders of the vagina and where things are with disorders of the bladder. I was in Vancouver the week before last at the International Urogyn Association, so I'm going to share with you some of the sort of cutting edge stuff that was just presented there to hopefully sort of excite you a little bit about what's new in our field. So we're going to start with fecal incontinence. And this is my son and my mother's ducks, and everybody in this picture has fecal incontinence. So fecal incontinence is defined as the involuntary loss of liquid or solid stool that is a social or hygienic problem. And so actually the ducks and my son don't have fecal incontinence, right? Because it's socially accepted. So with fecal incontinence, it's really happening when we don't expect it to happen. Anal incontinence is isolated loss of flatus. So fecal incontinence involves loss of liquid or solid stool. And fecal urgency is a very bothersome component of fecal incontinence, which is when you're unable to defer defecation for 15 minutes. So that's what we're talking about when we talk about fecal incontinence. And it's really more common than you'd think. And this is data from a paper I published when I was a fellow, where we surveyed about 6,000 women 45 years and older, just like surveyed through a consumer-based electronic survey panel. And 19% had had an episode of fecal incontinence in the last year. And 10% had had an episode of fecal incontinence in the last month. And you might think, well, I mean, it's a consumer survey and this was probably biased. There was some funding from a company that markets a device to treat fecal incontinence. But actually in the National Health and Nutrition Examination Survey, the monthly prevalence of fecal incontinence is the same. It's about 9% in women and 8% in men. And it actually does impact men and women. So we hear a lot about how obstetric anal sphincter injury is the leading risk factor for fecal incontinence. And I'm not saying that it's not important, but this problem impacts men too. So it's not just the sphincter. Um, the prevalence of fecal incontinence increases with age in both men and women, so that by the time we reach age 70, the prevalence of monthly fecal incontinence is more than 15%. And this is in community dwelling adults. This is not in people who are in nursing homes or institutionalized. This is in the people that are, going to church with us and shopping in our supermarkets. This is us as we age. 1 in 6 older women has fecal incontinence, and that's mostly because of the co-occurrence of fecal incontinence with really common disorders like IBS or other disorders of chronic bowel disturbance like Crohn's disease, ulcerative colitis, chronic constipation, or diarrhea. Diabetes and obesity increase the risk of fecal incontinence. Menopause increases the risk, as if you need another reason to hate menopause. Urinary incontinence is associated with fecal incontinence, and in damage related to childbirth, and in men, damage related to therapy for prostate diseases. So either surgery or radiation therapy can compromise continence mechanism. Most people with fecal incontinence actually have mild symptoms. So this is the Wexner score goes from 0 to 20. Anything more than 10 is considered severe. So you can see that most people have pretty mild symptoms. But even if you have mild symptoms, it's really bothersome. I use humor, but I don't mean to say that we should laugh about this condition. I really don't. It's just, when you're talking about poop, it's good to have humor. But this was the subject of a MyChart message I got from one of my patients with fecal incontinence last month. The subject line was, "Mine is a miserable life." And so when I showed you that data from that survey I did in fellowship where 19% of women had fecal incontinence, 97% of those women who'd had an episode of fecal incontinence in the last year reported bother associated with it. So it's different than urinary incontinence. If you have an episode of urinary incontinence in the last 6 months, it's not on your radar. If you've had an episode of fecal incontinence in the last 6 months, you might be staying at home and hiding. So this is more data from that survey I did in fellowship, looking at impact on quality of life. And in Ob-Gyn, we use something called the pelvic floor impact questionnaire. And there are 7 domains that are validated. And there are things like it impacts your ability to do household chores, it impacts your ability to participate in social activities, et cetera. And the dark alarming red here are the people who reported a severe impact in one of these 7 domains. And you can see the lighter gray. I'm going to see if this pointer, I should probably be doing this because it's being cast. The lighter gray is people who report being affected somewhat or slightly. And you can see the lighter gray goes beyond this big red line here is 50% of the people. So this is a universe of about 1,000 people who have fecal incontinence, but yearly, so not necessarily every week. And you can see that more than half report impact on quality of life and physical recreation, traveling more than 30 minutes from home, participating in social activities, impact on emotional health, and feelings of frustration. So it really is an impactful condition. And it's distressing and depressing. And these are endorsements of common sentiments. Half of people in this sample of 1,000 women with fecal incontinence feared having an accident in public. More than half wish they could get their normal life back. And, a pretty significant proportion endorsed feelings like, although I try hard to keep this condition under control, I feel like I'm fighting a losing battle. I have good days and bad days, and it's out of my control. So it's really a bad thing. And a quarter of people think they're the only one who has it. So it's a little bit different than urinary incontinence, where there's sort of this perception, you see the ads of like a field of people walking in diapers, and you sort of get this impression that, urinary incontinence is this really prevalent thing. Fecal incontinence doesn't have that same awareness. And so people do feel pretty isolated. And this is a quote from a woman here in Madison from a focus group I did when I first got here. "I think I have it under control. I'm keeping my secret. I've said to my daughter, who does ask some questions, make sure there's extra toilet paper when I'm here. I just say, I use more toilet paper than a lot of people to clean up, The older I get, you see, the more I think maybe I don't ever have to tell my children. I could have a stroke or a heart attack. They'll never know, just quietly die." So it's bad. But care seeking is really uncommon. So this is also data from that survey I did in fellowship, just to milk it a little more. The top line is women with fecal incontinence, and the bottom line is women with urinary incontinence. And the light green is feeling very comfortable talking about this condition with a doctor, and the dark red is feeling not at all comfortable. And you can see that the proportion of people who feel very comfortable talking about fecal incontinence is about 30% versus almost half for urinary incontinence. And that closely mirrors rates of care seeking. So less than 30% of women with fecal incontinence seek care, and 47% of women with urinary incontinence seek care. So most people with this really bothersome condition aren't talking about it with us. But when they do seek care, more than 50% do so with a primary care provider, a family physician, or a general practitioner. And so they're really the first line. And we are the first line, we're the second line for urinary incontinence, and we're in the top 5 for fecal incontinence. So women do talk to their OB-GYNs about these issues. So it is important for us to figure out how to handle it. This is another quote from that series of focus groups I did a few years ago. I did broach the subject with my doctor once, and she wasn't particularly helpful. And each time I have a physical, I think about doing it, and I just haven't done it again because I was unsuccessful the first time. And I heard that a lot. And I heard it, and it would make me cringe because I wondered how often I was that person who didn't know the answer, and so sort of unintentionally turned a patient off from getting more help. So this is a survey that Nicholas and I did a few years ago of primary care providers, including OB-GYN. So some of the folks in this room probably completed this survey, where we asked primary care providers in the UW system about whether or not they think screening for urinary incontinence and fecal incontinence is important, how often they screen, and how informed they feel. And what we found is that lots of people think that screening is important, but almost nobody is screening for fecal incontinence. And more people are screening for urinary incontinence, but rates of screening closely mirror how informed we feel to treat the condition. So that taught me that what I need to do to help patients is help providers feel informed about how to treat fecal incontinence, so that when somebody says, I'm having this problem, the doctor says, oh yeah, I know all about that. Let me tell you a little more. So I want to just spend a little bit of time telling you where we are with fecal incontinence in 2017. And we really are thinking outside the box in terms of therapies today. First of all, the term fecal incontinence is what we feel comfortable saying, but it's not what patients feel comfortable saying. In fact, 70% of patients with fecal incontinence prefer the term accidental bowel leakage. And the term bowel incontinence is preferred by about 20%, but fecal incontinence is only preferred by 6%. So I've really moved away from using the term fecal incontinence with my patients. I still use it with doctors because I find that there's a lot of pushback to the term accidental bowel leakage by doctors who are not used to that term, but that is the term that patients like to use. And I think it's not really so much about what term you use, but more about just talking about it. And I try to use whatever terms my patients use. So I have one lady who calls it her visitors. So every time I see her, I say, how are your visitors? You know, have you had any visitors recently? Just because anything you can do to make talking about poop more comfortable is good, right? So there are a number of really good treatment strategies. So when I was doing this research around barriers to care seeking, one of the big things was that people thought that there weren't effective therapies available, but there are. And so I want to share a little bit with you about the current therapies that exist and are available and how effective they are. So there's sort of steps to management, and the first step is optimizing stool consistency, and we'll talk a little bit more about that. And then the second step is modifying stool delivery, optimizing muscle strength, and then trying minimally invasive therapies followed by surgical options to optimize function and restore anatomy. So it's just like anything else that we do, right? We start with the least likely to harm and move forward from there. So conservative management. Anybody who's done the Ob-Gyn rotation knows we talk about Bristol stool chart. We talk about poop types all the time. The best types of poop are type 3 or type 4. Those are solid formed, they're easy to hold on to, they're easy to evacuate. Types 1 and 2 are the constipated types. Those can end up building in the rectum so that there's no space for new stool to be held. You know, the rectum is a reservoir, so if it's full, then there's nowhere for new stool to be held and it can slip out more easily. And then on the flip side, type 6 and 7 are the really loose stools, and those are hard to hold on to, just like it's hard to hold water in your cupped hands. So the first line management of fecal incontinence is optimizing stool consistency to try to get to that goal, type 3 to 4, with fiber supplementation and trigger avoidance. And it's the same fun things that we talk about with the bladder. So caffeine, artificial sweeteners, alcohol, spicy foods, chocolate. And then there are common medications that can contribute. So just a quick list, you know, any bowel medicine like a laxative or an antidiarrheal can cause bowel disturbances. Antibiotics, antacids, and NSAIDs are big players that a lot of people are on. And oral hypoglycemic agents are often cause changes in stool consistency that can lead to fecal incontinence. So first line management is just looking at what we can do without doing anything more than these things. And there is some evidence behind fiber. So there's two kinds of fiber, soluble fiber and insoluble fiber. And the bulk of fiber that we take in is insoluble, which bulks up our stool, helps hold water in the colon, and also gels the stool together. And then soluble helps colonic water absorption as well as cell metabolism. And this is these are the two types of fiber. Most fiber we get is insoluble, and they both help with both fecal incontinence and constipation. And the reason why is because with increased rectal distension, you have increased sensory awareness, which makes it so that you know when something's arriving and you have time to get to the toilet. Reduced liquidity of stools is self-explanatory why that would help. And more complete rectal evacuation also helps because of that, making it so that there's a reservoir again. So fiber supplementation is the first line therapy, and there's actually been a randomized, double-blind, placebo-controlled trial looking at various common fiber supplements. And the best one, the winner, is psyllium, which is what's in Metamucil. And so the red line here is the placebo, and so people had about 5 episodes a week, and psyllium is the gray line right next to it, and people went down to about 2 episodes a week. So you can cut symptoms in half at least by psyllium supplementation. Now the dose of psyllium for this trial was 16 grams. Does anybody know how much is in one serving of Metamucil? How many grams? Anybody know? Yeah, so it's 5. So you'd have to get 3 doses of psyllium every day in order to get what they got in this trial. And psyllium is actually the only of these fibers that resulted in a stool consistency that was gelling, which is one of the things we think is important for both constipation and diarrhea. So psyllium is kind of the winner when it comes to fiber supplementation. The other, to modify rate of stool delivery, if somebody is too loose and they're having fecal urgency and rapid stool delivery, then you want to slow them down. And 2 commonly used medicines are loperamide or Imodium and Lamodal. And loperamide is really the winner. It is more effective and has fewer side effects than Lamodal in terms of urgency. And when it's compared head to head with psyllium, remember the best fiber, it is comparable in effectiveness to psyllium, but does have more side effects. So that's why you try fiber first and then move on to loperamide. If somebody has the flip problem, if they're constipated and that's the issue, then polyethylene glycol is the first line go-to laxative, which is Miralax. It's superior to lactulose in terms of the number of stools per week, stool form, and side effects such as abdominal pain and gas. So those are the medications that would be considered first line. And then the other thing that's part of the first line therapy is pelvic floor physical therapy with biofeedback. And I want to talk a little bit about why that is, because every patient I talk to says, oh, well, I've tried Kegels and they don't work. So I want to talk a little bit about what pelvic floor PT does specifically with fecal incontinence. So there's 3 muscle groups that contribute to anal continence. There's your internal anal sphincter, and that's not under your control. That's the resting anal sphincter tone, that's involuntary smooth muscle. There's the external anal sphincter, which is what you can contract. And then there's your levator muscles, which are what you contract when you do a Kegel muscle, a Kegel squeeze. So those three muscle groups all contribute to anal continence. And what normally happens when stool is delivered to the rectum is that the internal anal sphincter actually relaxes. So that resting tone decreases when you get a load of stool, which sounds crazy. Like, why should that happen? But why that happens is because in the anal canal are the nerves that send the message to the brain to communicate to us what's in the rectum. So if it's gas and you're in a socially acceptable place, you can just let it out. And if it's diarrhea, then you've got to go. And if it's regular stool, you've got some time. So you need to be able to have the rectal contents go into the anal canal. But what happens, especially in patients as we age or if we've had a prior sphincter injury, is that when the internal anal sphincter relaxes, the external anal sphincter is supposed to contract, and that doesn't happen. So one of the things that pelvic floor PT can do is help women learn how to perceive that there's stool being delivered to their rectum by putting a balloon in their rectum and blowing it up and gradually blowing it up less and less so that they increase their sensation of there being something in the rectum, and then help them recruit the voluntary muscles that can contribute. So it's really not just Kegel exercises. And so if I've sent someone to a physical therapist who I don't know, I actually get a little detail about what did they do with you to make sure that they really are trying to target the pathogenesis of this condition. And we're really lucky at UW to have 9 pelvic floor physical therapists. And they actually just merged with Meritor. So I think we're going to have even more better access to them. And a lot of them they now rotate into our women's pelvic wellness clinic. So they see fecal incontinence patients with us in our clinic, and they know all of this stuff. Beyond that, there are some new products to manage skin irritation that I think are helpful to tell women about. One is butterfly body liners, which you can visit the website butterfly.com to find out where to buy them. They used to be available in every Target and Walmart and CVS, but the company changed ownership. And so I just tried to get them in a Target and they didn't have them. So you have to tell your patients to go to the website to find them. But they're basically, a lot of people with fecal incontinence tuck a little folded toilet paper into their buttocks so that they can catch the stool before it hits the pad. By the time it gets to the pad, like, you've got a mess on your hands with fecal incontinence because the pad's not right next to your anus the way it is next to your urethra. So lots of women with fecal incontinence fold a little toilet paper and tuck it into their butt crack. And what the butterfly does is it has adhesive that sticks to your bottom instead of sticking to your underpants. So it puts the solution where the problem is. And it's really effective for light to moderate bowel leakage. And then the thing pictured on the right here is the Renew rectal insert, which I actually have samples. So I'm going to pass these around so you can feel them. So it used to be, there were some anal plugs for fecal incontinence. Sorry. There were some anal plugs for fecal incontinence, and they were kind of like cotton balls or tampons. And so you can imagine that wouldn't be super comfortable in your rectum. And this is more comfortable in your rectum. I have not put it in my rectum, but my mentor in fellowship did. And he told me in the elevator, Charlie Nager, he told me in the elevator, he's like, "You really can barely feel this." And I was like, "Oh God, TMI, TMI." It's hard to embarrass me, as some of you might know. So anyhow, these are these little silicone rectal inserts, and I'm going to pass it around. So this part sits inside the anus. This part is meant to sort of block that internal anal sphincter relaxation and prevent stool from slipping when it relaxes. And this part is meant for you to be able to grab to pull it out. So where it sits in the anal canal is in this span. It's sort of, if this is the anus, this part sits inside the anus and this part sits outside the anus so that you can grab it and remove it. When I was a fellow, we were doing the first trial of this, and we had major problems. In a trial, you're trying to monitor compliance and how many devices people use, and you had to collect the unused ones, and people were just squirreling because this was so effective, and they didn't want to have to give them back. So I'm going to pass these around. And just, there's 2 of them. This is the applicator and the device. Just please don't walk away with them. I desperately need them for my clinical practice. So they are a little bit expensive. I'll show you data. And then the other talk that I have with patients with fecal incontinence all the time is about taking care of your bottom the way you would take care of your baby's bottom. So just like use moist alcohol-free wipes and dab. Don't wipe. Toilet paper is made of wood, just like all other paper. It can traumatize that skin, and that skin, it's not like that skin gets rougher as we age. It's always really tender. And then using a barrier cream like zinc oxide or Desitin to protect it from that chronic irritation. So in that trial that I was talking about at UCSD, there were 85 subjects enrolled, and their mean number of episodes went from 6 per week to 1 per week at 3 months. There were no device-related serious adverse events. People did experience mild rectal irritation and urgency, and the cost for these inserts is $100 for 30. So if a woman has somewhat predictable fecal incontinence, or if the time when she really doesn't want it to happen is when she's at church or something like that, then this might be a good option for her. But if this is somebody who's got 5 loose bowel movements per day, this is a very expensive therapy. If you can prescribe this, anyone can prescribe this. If you Google Renew rectal insert, you can find the information. And it's either $30 for a pack of 10, which is 5 regular and 5 large, or $100 for a pack of 30. So I usually just prescribe the $30 pack of 10, and then women can try them. And then if she likes them, we can order whatever size she likes. Did you have a question? Yeah, so in the trial, people did try to clean them at home. And the company, when we were doing the trial, the company said that they were flushable, but I think most people don't flush them. So that is one thing that's a little bit about these, is that you have to actually grab it out of your bottom and throw it away. So I'm going to move on to talking about the Eclipse vaginal bowel control system, which is the new pessary to treat fecal incontinence. We are the second academic institution in the country that is prescribing these outside of a clinical trial at this point, so that's pretty exciting. So the Eclipse vaginal bowel control system is a pessary that sits inside the vagina, just like any other pessary, and it has a inflatable balloon that reversibly occludes the rectum. So this is what the fitting device looks like. There's a trial insert and then a real insert. And so you can imagine the device sits inside the vagina, and the tubing hangs out of the vagina like a tampon string. And when women want to have a bowel movement, they deflate the balloon. So without removing the device, the device stays in the vagina, and then the pump has a little minus side and a little plus side, and you just connect the minus side and you pump until the pump sticks together, and that tells you that all the air is deflated from the balloon. And then you can have your bowel movement, and then when you're done, you just reconnect the pump now with the plus side and you pump it back up. So when I first heard about this therapy, I was really skeptical. I just thought there's no way that that's actually going to work. But it does, and I'll show you some data. I am also going to pass around I have one of this is the commercially available pump. The previous generation of the pump was this one, which we used in the trial. So I'm going to pass them both around. They work interchangeably, so you can have some fun with this fecal incontinence pessary. And I did put this picture of this lady straddling the toilet just to say that this device is not for the lady with vault prolapse who needs a cube pessary that stays in for 3 months at a time. This device is a lot of effort. You have to be able to you do have to be able to remove it. It's not, you can't stay in for 3 months at a time. And you've also got to be able to manipulate the tubing. You've got to be able to pump it up and deflate it. The tubing wants to fall in the toilet every time you sit on the toilet. So you have to have a system where you hold up the tubing or you tape the tubing to yourself. If you're obese, it's hard to reach the tubing. We can put a tubing extender on there, but that's another limitation. So I have now seen a few patients who were referred because somebody heard about the device, and then there's no way that they're a candidate. I mean, you've got to be relatively cognitively intact, and you've got to be able to put things in and out of your vagina and manage this tubing. It's different than a tampon string, because if you get a dirty tampon string, you just throw away the tampon. This is a tubing that's always there and it's connected to the device. So it is a little bit more maintenance. But I'm not hating on this device. I love this device. It really, really has improved quality of life for a lot of my patients, but it's like anything you have, it's all about patient selection. So in the initial trial, the life study of the Eclipse, there were 110 women enrolled and 61 subjects successfully fitted. So that's about what we see with other pessaries to treat pelvic floor disorders, about a 50% rate of successful fitting. And the mean reduction in episodes of fecal incontinence went from 6 episodes a week to 1 episode a week. There were no device-related serious adverse events, and the most common side effects were pelvic cramping and discomfort, especially during fitting. If you have a patient who you think is a good candidate for this therapy and you're going to send her to me, if you could start her on vaginal estrogen ahead of time, that would be very helpful. Because I have not yet had a patient who didn't need vaginal estrogen with this device. It's just bigger than other pessaries, and it connects with a lot of the vaginal epithelium. And when I had my sort of like come to Jesus moment with this device is when I finally did a rectal exam with a woman who was wearing it in her vagina, and I felt my finger go into the rectum, hit the balloon, and then be pressed between the posterior wall of the rectum and the balloon. Like there was no space to get through. That's not saying I couldn't push my finger beyond it, but it actually does occlude the rectum, which I didn't believe just by looking at the pictures. I thought there's no way it really occludes the rectum, but it does. Okay, there's another therapy which has been around for a number of years now called Celesta. It's an anal bulking injection using a dextranomer spheres, and we do it through an anoscope. So this is a picture of what it looks like when you look through an anoscope, and you inject it above the dentate line, so there's no pain fibers there. And you basically put in 4 little marbles of material that should act to sort of similar to the Renew insert, should act to sort of catch stool before it comes out. Truthfully, the treatment response was 52% with this treatment versus 32% with sham. Most women end up getting 2 injections, and in my practice, I haven't seen anybody really improve. So I'd be hard pressed to tell you who's a good candidate for this, but this is another one where people send patients to me for this therapy, and then I evaluate them and say like, oh, I think we should try this other thing for you. And so if a patient isn't a candidate for these minimally invasive office-based procedures, we could talk about surgery. And there are 3 surgeries that I think are sort of the common ones that are performed. There's sacral neuromodulation, there's sphincteroplasty, and various other variations of that performed by our colorectal colleagues, and there's colostomy as an end resort. Sacral neuromodulation has really revolutionized the treatment of fecal incontinence in the last 5 years. The complete resolution of fecal incontinence is what's presented in this. So about 1/3 of women in the first group, 40% in the second trial, and 50% in the third trial have complete resolution of fecal incontinence. But 85% have at least a 50% reduction in the number of fecal incontinence episodes per week, which is sort of the accepted improvement for this condition. And even if a woman doesn't meet the 50% reduction, she's often so grateful even for a 25% reduction in symptoms that she wants the device implanted. And I don't know, InterStim's been around a while, so maybe everybody's already seen InterStim, but I do have here what the battery looks like. So the way we do InterStim is we put a wire in through the skin of the back. It goes to the S3 nerve that drives the bladder and bowels and the pelvic floor. And we do a test period. And if a woman feels like it's helping her, then we implant this permanent battery, which lasts for 3 to 5 years, depending on the level that she has it set at. And this little battery is just like a pacemaker battery. It sits under the fat pad of the buttocks, and she can use this little remote device. She can put this over her battery that's implanted under her skin, and she can actually turn up or down the stimulation, and she can change which program it's set on. So this is a therapy, again, that requires a patient with a little bit of, you know, she can't be demented to use this therapy. But this is another therapy that's really effective. And it's, people are scared of implants. You know, people are always scared of having a permanent implant in their body. But the sort of my selling point with this therapy is you're subjecting yourself to some anesthetic risk. But if this doesn't work, we pull out the lead and you're done. You know, it's not like a sphincteroplasty where we might damage your muscles and lead you to have worse fecal incontinence down the road. So it's really, I feel like patients have this impression of it being a huge deal, and it's really a pretty minor procedure. And if it works, it's revolutionary. I was giving a talk last year at a Crohn's and Colitis Foundation support group about fecal incontinence treatments. And there was actually a guy there who'd had an InterStim for urinary incontinence. And he was like one of the members in the support group. And he was like, oh, guys, I've had that. It's no big deal. It's really, and I was like, oh, this is great. This is exactly what you need. It's like patient endorsement. You know, sphincteroplasty, when I was a resident, I feel like this was what we offered patients with fecal incontinence in their 50s or 60s. And there's debate about overlapping and end-to-end. And since InterStim has come out as such an effective therapy, we've really sort of seen a decrease in sphincteroplasty, except in people who have an acute injury and an isolated sphincter defect. Because if you think about the development of fecal incontinence symptoms, if it's happening right after a vaginal birth, then sphincteroplasty makes sense. But if it's happening 30 years later, then it's probably not that anal sphincter injury that happened at the time of a delivery that's really the problem, right? It's this multifactorial thing that has to do with a bunch of things. And so I think why InterStim is so effective is because it improves muscle and nerve function of not just the external anal sphincter and internal anal sphincter, but also the actually bowel peristalsis and resting anal tone, et cetera. And there are some, sphincteroplasty is a relatively morbid procedure with the potential to worsen symptoms. Artificial bowel sphincters are not currently recommended. They are very effective, but the side effect profile is not favorable enough to recommend them, so they're recommended against. And colostomy is an option, and these are photos. There's a campaign to sort of increase awareness of, you know, life after colostomy. Like, you can swim with it, you can enjoy, you can exercise, you can enjoy your life. And so I do have patients who have had a colostomy for their fecal incontinence. There are some things on the horizon. There's a magnetic anal sphincter that's been tested in colorectal, with our colorectal colleagues, and they actually just announced in April that the company is no longer making it. They said for economic reasons, not for anything related to the device, but it sounds like it's gone the way of all the other artificial bowel sphincters. On the lower left here is something called SECA. It's a radiofrequency ablation technique where you put this probe into the anus and then these little curved metal spheres come out of it and burn the tissue. I don't recommend it. And this is Topaz. This was a sling for fecal incontinence. It was made by AMS. It did have promising results in a clinical trial, but AMS folded, so it's not available. And there are some very early studies on stem cell research and injecting stem cells into the anal sphincter to improve fecal incontinence. Posterior tibial nerve stimulation is a therapy that we use for urge incontinence, where we stimulate the S3 nerve, but rather than placing a wire through the back, we actually place the wire through the ankle, because, you know, the nerve goes all the way down, and we stimulate the S3 nerve that way. It does work pretty well for urge incontinence. It doesn't work very well for fecal incontinence, but the Pelvic Floor Disorders Network is actually about to do a randomized trial of it to treat fecal incontinence, so we'll have more data. So I want to pause here for a moment and ask if folks have any questions about fecal incontinence before we move on to just like the brief updates of what was presented at IUGA. Yeah. Yeah, probiotics. I don't know the answer to that, but I certainly am recommending it to my patients clinically. But I don't know. I haven't seen a randomized trial of probiotics for fecal incontinence specifically. Good question. Sorry, I don't have more information. Okay, so now I'm going to move on to the vagina. So I was at IUGA in late June in Vancouver. This is one of my medical students giving an oral presentation. She actually had to stand on her tiptoes to see the screen in front of her to see what was on her slides. So one of the featured talks at IUGA was titled "What's the Moral of the Mesh Story?" and it was given by this Canadian Jeff Cundiff. And it sort of just underscores the debate that's going on in our field right now around pelvic organ prolapse surgeries and the use of synthetic mesh, which all of you have heard about. One of Eric Jalovsik, who's a Urogyn at the Cleveland Clinic, presented data from the extended Optimal trial. So Optimal was a randomized trial of 2 different apical suspension procedures to treat prolapse. It was randomizing women who had apical prolapse and wanted surgery. It was randomizing them to doing a uterosacral ligament suspension or a sacrospinous ligament suspension. And the initial data the primary outcome was 2 years, but we just heard the 5-year data. And so this is the survival probabilities. So how likely is your operation to still be working? So symptomatic failure was defined as bothersome vaginal bulge symptoms. And you can see after a native tissue repair, 5 years, about 40% of women have developed bothersome vaginal bulge symptoms. Anatomic failure rates are even lower, or even higher. Anatomic failure was defined as the apex, the top of the vagina, being at least 1/3 of the way down the vagina, or having the front or back wall of the vagina out beyond the opening of the vagina. And those rates you can see are drop down into the less than 50% of women 5 years after a vaginal approach still have anatomic cure. So overall, 10% of women elected for a repeat treatment, 4% had a pessary, and 5% had an operation. So when you're counseling a patient about if you're doing her operation for prolapse, you're saying, well, at 5 years, you have about a 10% risk of needing another treatment for prolapse and about a 40% risk of having some vaginal bulge symptoms that are bothersome. So that is sort of what led us all these years ago to start doing all these repairs with mesh, thinking that we could improve success rates. So, the 60% success rate at 5 years using native tissue. This is data from the eCare study, which was women who underwent abdominal sacrocolpopexy, which is using synthetic mesh. And their risk of having symptomatic bulge at 5 years is 25%. So we used to always say that sacrocolpopexy was the gold standard. It was our best apical prolapse surgery. But really, if you look 5 years down the road, 1/4 of women have bothersome bulge symptoms, and 10% of women have experienced a mesh exposure when you get 7 years out. So this is sort of the quandary we're in with urogynecology right now and surgical options for pelvic organ prolapse. And you have some urogyns who look at this and say, hey, 60% at 5 years, that's not bad. Only 10% are getting another operation. Then you have other people saying, well, that's unacceptable. We need to do better. There are a couple of randomized trials in progress through the Pelvic Floor Disorders Network. SUPER and ASPIRE. SUPER is a randomized trial where women are randomized to a vaginal hysterectomy with a native tissue repair versus a hysteropexy with mesh. So when you wake up from your operation, you may or may not have a uterus and you may or may not have mesh. So that's one trial that's going on right now. The other trial that's going on right now is those arms and sacrocolpopexy. So when you wake up from your operation, those two options, plus you might have had an abdominal operation with mesh placement. And these are, the Pelvic Floor Disorders Network is funded by NIH. It's very competitive. It's probably the top research institutions in the country in Urogyn. So I'm sort of making light of it, but not really. I mean, we really are in a quandary in our field about how to surgically manage prolapse and do best for our patients. And we do see now this hesitation to embrace new therapies as a result of what we've learned about complications from mesh. So one of the debates was blinded by or seeing the light, the use of a laser for treatment of vaginal atrophy. And it was a big featured debate on the second to last day of the conference. And initially there were like 10 people in the audience who said laser was okay. And by the end of the debate, there were only 3 people in the audience who voted that laser was okay. So we're definitely seeing in Urogyn this like drawback where we're saying, wait a minute, we need long-term data before we embrace new technology. Okay. All right, and then last, I just want to touch on some of the updates in urinary incontinence treatment that are happening in our field right now. And I want to say that when it comes to mesh, we are not throwing the baby out with the bathwater when we're talking about the treatment of stress urinary incontinence. OGS, the American Urogyn Society, and the Society of Urodynamics and Female Pelvic Medicine and Urogenital Reconstruction, SUFU, have put together this really compelling position statement for providers, and they also have one for patients. And I just want to read to you sort of what I think is the thrust of it. The polypropylene mid-urethral sling has helped millions of women with stress urinary incontinence regain control of their lives by undergoing a simple outpatient procedure that allows them to return to daily life very quickly. With its acknowledged safety and efficacy, it has created an environment for a much larger number of women to have access to treatment. One of the unintended consequences of this polypropylene mesh controversy has been to keep women from receiving any treatment for stress urinary incontinence. This procedure is probably the most important advancement in the treatment of stress urinary incontinence in the last 50 years and has the full support of our organizations, which are dedicated to improving the lives of women with urinary incontinence. So mesh for prolapse might be bad. Mesh for stress incontinence, we are on board. Although, interestingly, we did see researchers from some countries at IUGA presenting data that they're abandoning the transobturator tape in favor of just the retropubic tape because of the increased risk of mesh-related complications with the transobturator approach, which are harder to manage, even though the retropubic approach is a little bit riskier. So it's kind of interesting to see the way that we're going as a field. I just think this is the coolest thing, so I'm going to share it with you. It's not commercially available yet, but I think it's really cool technology. It is a balloon inserted into the bladder and filled with compressible gas that acts as a shock absorber to treat stress urinary incontinence. So, the mechanism of action for stress urinary incontinence is that increased pressure in the bladder gets transmitted to the urethra. The urethra doesn't have enough resistance to prevent the leakage. So this balloon is in there and it expands and contracts based on the pressure in the bladder and acts as a shock absorber. There was high intolerance to the device. I think like one of the things they presented was like, it's all about figuring out which patients are going to tolerate having something bopping around in their bladder. But interestingly, nobody got stones on this device in a year of having it in place, which is really unusual for something in the bladder. But the folks presenting said they think it's because it expands and compresses. So that's something that's like coming down the pike that is an interesting therapy. It's easy. This is pictures taken from their website. You put the balloon in, then you put the gas in it, and then a year later or sooner if they're having problems, you grab it, deflate it, and pull it out through that same little introducer. And then one of the other big things that's coming up about urge incontinence is the impact of anticholinergic medications on cognitive function. So I don't know if folks have seen this, but anticholinergic burden is a real thing. Lots of medications have anticholinergic properties, and anticholinergics do bad things to our cognition. And so the ACB score is the anticholinergic burden score, and for every 1 point increase, there's a doubling in all-cause mortality. And so this was data presented by a group out of the UK, and they concluded that prescription of antimuscarinic medication increases the anticholinergic burden to an arguably unacceptable level for the majority of women with overactive bladder. And the common anticholinergics in this study were things that we see commonly prescribed: lansoprazole, levothyroxine, omeprazole, and sulfenacin, which is one of ours, that's care. So there is one medication that you can prescribe called mirabegron, which is not an antimuscarinic, and we're moving more towards that in folks in whom we're concerned about a cognitive burden. But I'm hoping that in the next decade, we'll see a sort of recognition that we don't need to try anticholinergic therapy for everybody before we approve alternative therapies. I'm hoping we'll see a move away from this, given what we're learning about the impact of our medicines on our brain. And then the other therapies for overactive bladder are posterior tibial nerve stimulation, that ankle stimulation, or sacral neuromodulation, the same as for fecal incontinence, or injecting Botox into the bladder. And one of the recent Pelvic Floor Disorders Network studies found that Botox was superior to InterStim in reducing the number of episodes from a statistical perspective, but the authors questioned whether or not that was a clinically significant reduction in incontinence episodes, and it is associated with a higher risk of urinary tract infection and repeated trips to the operating room to re-inject. So that's sort of where we are with overactive bladder treatments in 2017. Looking forward, the American Urogyn Society has created a national registry of patients undergoing therapy for pelvic organ prolapse. There are lots of genome-wide association studies going on in our field. There have been a couple candidate genes identified for risk of prolapse and risk of urge incontinence. There are lots of microbiota studies. So microbiota is all the bugs living in our system. Microbiome is their DNA. So a group out of Loyola has done a lot of work looking at the bacteria, the DNA of bacteria that live in the bladders of women with incontinence who have negative urine cultures. And what we're finding is that the bacterial profiles look different. So probably our urine cultures aren't sensitive enough to pick up some of these bacteria that may be contributing to symptoms. There are a lot of models for risk prediction happening in Urogyn. Things like, can we tell a woman what her risk is of developing fecal incontinence and urinary incontinence after a vaginal birth? Can we tell a woman what her risk is of developing stress incontinence after a prolapse procedure? They presented a model for risk prediction for subsequent pelvic floor disorders after vaginal delivery at IUGA this year. And the model predicted correctly 51% of the time. So we're not there yet. And I think we've learned as a field that we really need to proceed with caution with our embracing new technologies. And so you see us being cautiously optimistic as we're moving forward, having learned our lesson from sort of early adoption and widespread implementation of vaginal mesh. And that is it. I want to close with a final quote from a woman who was a participant in one of my focus groups. And this is just, you know, we said, what would you want providers to do? And she called out GYN. That's who she wanted to talk to her. At my annual GYN exam, I would want for the provider to ask about any troubles peeing, urinary or anal, or ask about my pelvic floor. They could put it on a form you fill out. This would be my fantasy doctor. They'd say, is there something you want to talk to me about your health that you've never brought up and you're too embarrassed, or you want to make another appointment to talk to me about? That would be my fantasy, because I never get to do that. I'm a very shy person. I think it would be creepy if a doctor said, is there anything you want to talk to me about that you've never told anybody? But I do think it's a really good point. You know, like, we're scared to ask because it's awkward and uncomfortable, but they really want us to ask. And we're the dealers of the information. So I would just hope that you would think about talking more about these uncomfortable nether regions. And that's it. And I welcome your questions.
All right, who would like to ask some questions? Anybody? Hello. Yes. We don't actually do the well women exam, so I haven't the slightest idea. I In Urogyne, we don't do them, but I think in yes. I would say that's a common thing that I hear is I wish my OBGYN would have asked me this or told me, which, we all know you got 12 billion things you're trying to do, and this adds one more thing to the list of things.
Urinary incontinence screening is often a quality measure, and so it's built into a lot of forms, but fecal incontinence screening is not.
Yes.
Oh, that's a great question. So the question is, how do you make decisions about which treatment to try first when you have a new patient with symptoms? And I tried to fit into this talk our algorithm. Our nurse practitioner made some really awesome, she's right over there, Angie Sargent. She made some really beautiful summary algorithms. So we actually just pull out an algorithm that shows the patient, like, this is your roadmap. We're going to start here. These are the things. If these things don't work, here's where you go next. And it depends on how much time you have to talk about it and what the patient's level of interest is. I find I have to do a little bit of education about the sort of pathophysiology in order to get buy-in for the conservative management treatment strategies first. So I end up doing that, and then a little bit of, and there's all these other things that we can try moving forward.
Next, anybody? Okay, since it's top of the hour, I want to thank Dr. Brown. It was a very informative and funny talk. Thank you very much.
Thank you.